Good afternoon and welcome everyone. My name is Mandy J. And on behalf of the Early Hearing Detection and Intervention National Technical Resource Center, or the EDI NTRC, I want to welcome you to this webinar, Assuming Competence, What to Do If You Don't Know What to Do, presented by Michelle John. Before we get started, I have a few logistical items to run through for you. You should know that this webinar is being recorded and will be posted on infanthearing.org in the next couple of days. So if anything disrupts your full participation today, please know you can access our website, and you will also be able to share this webinar with others who will benefit from the content by going to infanthearing.org. Also, if you would benefit from captioning today, please click on live transcripts or show captions, and you will be able to activate captions for this. You can position them and enlarge the size to however you would like to view them. You'll notice that there's a vertical bar between the PowerPoint slide and where the video windows of our interpreters and presenters are. You can resize these two fields, moving the vertical bar to the left or the right for your viewing preferences. Thank you so much to our captioner and our interpreters today. We appreciate your time and your skills to bring accessibility to everyone participating in the webinar today. So thank you to them. Okay, so a couple more things. After our presenter has completed her presentation, we're going to open up a Q&A box where you can type your questions for the presenter to respond to. We will not be monitoring questions during her presentation, so we ask you hold off until we open that Q&A box. Just jot down any questions you have so you don't forget them by the end. At the end of our webinar, we will be posting a link in the chat box that will take you to a short evaluation of the webinar, and it will also produce a certificate of attendance if that is helpful for you. So be sure to do that before you sign off today. So with that said, I want to introduce Michelle John, our presenter for today. I'm going to read a bit of her bio, but I don't want to interrupt her presentation time or take too much presentation time away from her, because I've heard her present before and it's great, and we want to maximize her time. Michelle holds a dual Bachelor of Arts degree in Psychology and Sociology from Hofstra University and her Master's of Science degree in Community Counseling and Psychology with a specialization in addictions counseling from Springfield College. She also earned her certification as an end-of-life doula through the University of Vermont. Currently, she is in the final portfolio stage of becoming a certified deaf-blind intervener. She is also a newborn screening ambassador for Expecting Health, works closely with the National Center on Deaf Blindness, and is a governor-appointed member of the Vermont Developmental Disability Council. While spending many of her adult years enjoying pursuing higher education and proud of these accomplishments, she is just as quick to share life sent her in a divergent direction. Her highest achievement comes from raising and educating her 3 children by being a stay-at-home parent. She is all things medical, educational, coordination, and physical care to her 9-year-old DeafBlind Plus child who has a variety of significant medical complexities, and she's a willing teacher to those with questions and readiness to learn, most often her 2 other children. So with that, I want to turn this over to Michelle, and I'll be back on with questions at the end of her presentation. Michelle, thanks.
Thank you so much, Mandy. I appreciate that. I'm embarrassed at that, but thank you. I want to say good afternoon from snowy Vermont. We had our first snowstorm today, so that's been exciting. And I thank you very much for joining me. So this presentation, I always like to give a warning that this session may cause tears or changes in your outlook on how you interact with your child or a child you work with, and possibly even your organization as a whole. This is a raw presentation about a child that I love and adore, but some of this child's history will be given, which can be emotional or blunt. Due to time constraints, I feel that honest facts will be the best policy for you to get the most out of your time from this session. Don't fear, it won't be doom and gloom the entire time, but to have facts are critically important for you to understand how practitioners, service providers, and even family members can be influenced by what is often considered the standard. This can limit a child's connection, progress, and interaction. Some of the items I share may invoke strong emotions ranging from joy to sadness. And this program is unrated, though approved by NCHAM. And I certainly promise that this will be a great session. Now, let's see if I can make it move to the next slide. There we are. So assuming competence, we're going to watch the next slide, and there'll be a couple of video clips. I want to acknowledge that sometimes it's easy to assume a child does not have a particular set of skills and act accordingly. Noticing and naming these feelings that come up within us may help us to take action to improve our connection, skills, and level of professionalism. So please notice what emotions you may have while you watch these videos.
Wow, buddy, it's your mama. Yes, mama. Good job, mama. Oh, I think Sissy wants to borrow your toy. Hi, Sissy. Nice job sharing, bud. Wow, honey. You did. Nice job talking. Yeah. Hey, Tyson. Is Mama taking videos of Tyson? Yeah, you see something over there. Who did you see? Is it your sister? Or your brother? Oh, you hear your brother Lane? Yeah, he's over there. That's right. Yeah, you want to see. What are they doing? Do you want to go and look? Yes, I want to look. Good job, bud. We'll go and see your brother now, okay?
So think about the emotions you felt while watching those videos. Perhaps you felt happiness, connected, confused, or overwhelmed. You may have had other feelings, and feel free to investigate those as well. So who is that child from the clip? It's Tyson, a DeafBlind Plus child. He was born deceased via an emergency C-section, revived after 17 minutes of no oxygen, put on life support and a cooling mat, and extubated on day of life 8. He was expected to die immediately. The EEG showed minimal to no brain activity, but 4 seizures. The ventilator showed no voluntary breaths. Surprise, he lived, but he's a vegetable with no awareness. He was brought home at 6 weeks old to die. Some of the many diagnoses, and both the captioner and interpreter will hate me for these, but cerebral palsy, hypoxic ischemic encephalopathy, which is a brain injury, spastic quadriplegia, epilepsy, cortical visual impairment, bilateral sensory neural hearing loss, and failure to thrive. Some of the technology needs to keep Tyson going include oxygen, BiPAP ventilation, suction, feeding tube and pump, a wheelchair, hospital bed, and oximeter. He's had multiple hospitalizations and a short life expectancy. So I wanted to share a brief history of how this beginning stage of life went. And please know I'm only giving some of the many diagnoses and technology needed to keep him going. There's so much more to discuss, and we don't want to spend our time talking medical jive. So after being told Tyson had no brain injury with brain damage in all 4 quadrants and the brain stem, we were informed he had no awareness of who he, we, or anyone was, nor where he was, or anything. He was in a vegetative state and his brain function was being used solely to breathe, sometimes even forgetting to do that. And his heart function. Only basic life-sustaining measures, which were involuntary. No other function was available. Due to the significant brain damage, he would soon forget to breathe or keep his heart going and would die. Any second now. Wait for it. Wait for it. Any minute now. This could be it. First, it was to be over at day of life 8, then not live more than 1 month, 2 months, 3, then 6 months. He won't live a year. He won't see age 2. After turning 3, they stopped telling us what age he would survive to. I would wish and hope for more, though secretly terrified what even one more day would look like. Tyson is my firstborn child, and that terror mixed with what I now know is PTSD and birth trauma equated a mother whose anxiety was on overdrive for 24/7 for years, unable to sleep and some days barely able to think, and I was certainly no medical professional. How could I possibly know how to take care of this failure to thrive baby who could not see or hear, feel, or know? His eyes would be open at times, but he was looking through things, never at. No sign of recognition of anything, just like they said. So what do you do with a comatose kid? Caretake was all I could, so I did it with vigor and gusto. I would be the best damn caretaker there'd ever been. I would be a personal pediatric intensive care unit. I would be the team of professionals it took while inpatient, all wrapped up into one person. Now, this is all relevant and important information, and certainly the medical history is important to have. But is there more? Perhaps things that are equally as important. Well, the information on the previous slide is critically important to understanding the history of how a child became who they are. Let's reflect on the possibility there is more to said child. Let's look at these next 2 slides together. So who is that child from the clip? Tyson, a DeafBlind Plus child. Baby Tyson. He has a significant medical history with limited life expectancy, multiple diagnoses, and medical equipment requirements to sustain life. He's adorable and sweet. He enjoys listening to music. Itsy Bitsy Spider is thought to be a favorite. He likes feeling toys, going for walks, stores, and shopping. His parents think they're projecting. He loves to be held and snuggled, needs warmth and comfort. His favorite non-human cuddling companion is Gina, a huge, old, all-white, long-haired cat whose preference is to lay on his legs, the part of his body that is always cold due to poor circulation. I'd like you to ponder for a moment what is here. Is it a lot or a little? Do you know baby Tyson very well? Can you convince yourself you do actually know Tyson? Does the family? And what if this was your child? So now let's look at information regarding older Tyson. You'll immediately notice there's a lot there. This slide is visually busy, but you'll also notice a keyword shift. So who is that child from the clip? Tyson, my DeafBlind Plus child. He has a significant medical history with limited life expectancy, multiple diagnoses, and medical equipment requirements to sustain life. He has an amazing sense of humor, loves to laugh and smile. He loves listening to music, classic rock, Bob Marley, the Bee Gees, Beach Boys, Katy Perry, Whitney Houston, and annoyingly John Mayer are favorites. He enjoys feeling toys, going for walks, stores and shopping, watching the iPad, seeing his classmates, his siblings, looking at and listening to stories, Pictello books, working with favorite providers, all things water, his hair being washed, brushed, or stroked, snuggles with family, siblings and pets, lava lamps, disco balls, camp, maternal grandparents, going on boat rides, movement, silly voices, soft, cozy blankets, being warm, stuffies, getting haircuts, compliments, and picking out clothes that are cool looking. What does Tyson hate? Poopy diapers, old school country music, randomly Jack Johnson's music, being cold, being alone, boredom, pain and discomfort, jackets, doing schoolwork he does not enjoy, and seeing providers that don't get him, prolonged loud noise or chaos, and blood draws. Now that was a lot that I read. When you compare baby Tyson to older Tyson, is there a difference in detail? Do you feel you know Tyson better now? Is he now a more well-rounded person for you? Perhaps an expanded version of baby Tyson? And did you notice that one key word shift? He's not a child, he's my child. Does that change the meaning for you? And how do we get from the first slide of doom and gloom medical history to kind of learning about Tyson to really knowing Tyson? So interactions with families, words and behaviors matter. For families of children with significant or multiple diagnoses and disabilities, they may be overwhelmed, confused, or scared. Your words in regards to their abilities and skills, the child's capabilities, and your views about them have a much stronger influence than you may realize. I'm now going to give you a few rapid-ish examples. I'm going to start with a simple one, calling me not by my name, but calling me Tyson's mom. Not all families like this. I don't mind it per se, but no one has ever actually asked me. I don't actually go by mom, and mommy isn't a favorite either. I chose mama, and it is my preference. I don't love being relegated to just Tyson's mom, although I'm extremely proud of that earned title. However, I am more than just a mom. I suggest always asking. Don't assume people's comfortability with names or labels. Now we're going to go a little deeper. During the first 2 weeks of Tyson's 6-week inpatient stay after birth, his neonatologist allowed Tyson to have donated breast milk, as I was pumping like a fiend and from birth but producing nothing. Breast milk was literally the only thing I felt I had control over at the time, and I couldn't even manage to do that correctly. Breast milk is best was the mantra I'd always heard. My body had already killed my kid, and now I couldn't feed him. What could I do correctly? I was utterly defeated standing by to watch my child die. During rounds on another neonatologist shift, I overheard this unknown doctor share to a large medical team, including a slew of residents. He couldn't understand why the other doctor was allowing a dying child to waste the donor breast milk. I wasn't able to touch or hold Tyson until day of life 5 for a variety of medical reasons. On day of life 8, Tyson was to be extubated, meaning remove his life support, to let him go. I'd only had 3 days to touch him and only a few holdings. A few minutes prior to extubation, I was holding him skin to skin, chest to chest, as I had for every moment I was allowed. It was a lot of hard work to get him skin to skin, but keep the tubes in. I knew the hour was upon us. I had read all the books I thought he should hear, picked the grass and leaves for him to experience the outside world one time. We'd taken the pictures, one of which you saw on the opening slide. I was saying my lengthy goodbye. Squeeze. No, that can't be. He wasn't really squeezing my chest. Squeeze. It's just a reflexive action, they said. During my ridiculously drawn out goodbye, I told Tyson we'd love him no matter what, and we would never, ever, not for one single moment, be upset or disappointed if he felt he couldn't continue. He was in charge. He would choose and we'd follow his lead. I shared we understood if it was too much for his body or brain to go on. He was enough for who he was and what the situation was, and we were so proud of him for trying. You lead, son, and we'll follow you anywhere. We had no idea at that time that moment was assuming competence. As the entire medical team, my parents, and Tyson's father circled around, I clumsily clung to my child, squeezing so tight while the tubes were removed. Not one breath, they reminded us. We waited. Then it came. And again and again. Involuntary reflex, it will stop soon. But no, Tyson just kept breathing. This makes no sense, they said. He never took a voluntary breath while on the ventilator. It did all the work. And I said at the time what felt like the dumbest thing, but now realized was completely accurate. Shrugging, I said, he was just resting. No need to work when you don't have to. Another example, as Tyson continued to live, he was switched to a gastrostomy tube, which required a sedated surgery. Though he was a little over 2 weeks old at this time, because he was not there, they gave him no pain medicine whatsoever. He kept making this teeny tiny noise. I'd never heard him make a noise. It seemed voluntary, and it wasn't him breathing funny. It was barely audible if there was too much background noise, but it was a noise. I just knew he was in pain. I paged assistance and a resident came by. He asked, how would I possibly know if my child felt pain? When they did the pain response test, pinching him, there was no response. Have you had a literal hole bore into your stomach and had no pain meds? Because that's what my baby was enduring. I said, I don't know for sure he's in pain, but he's always been this one way, and now it's different. This resident thought I was out of my mind and projecting. He told me I wasn't willing to accept the reality my child was not there and did not know a surgery had occurred. Lo and behold, after much discord, to appease me, the postpartum dramatic mother, they gave Tyson pain med, and the noise stopped. During an outpatient visit, a neurology head nurse told me I had to decide what type of mother I wanted to be, after stating I thought Tyson's seizures could be better controlled. Did I really want to be a mother who lived in an After stating I thought Tyson's seizures could be better controlled, she said, did I really want to be a mother who lived in an alternate reality where my child could or should receive treatment? She questioned why I was so insistent he should live and suffer, let nature take its course instead. She said I was being selfish and should really reevaluate what type of mother I wanted to be. Seriously, she quietly chided, you have issues. Within that same office on a different visit, I stated I knew there was something wrong with Tyson to the neurologist. Tyson could not move his body voluntarily, but he was acting like, for lack of a better term, a malfunctioning robot. She scoffed, told me that was impossible, and I was just wishing Tyson could do something. I denied this theory and reminded her I'd been the one to set up the appointment because I was seriously concerned about the malfunctioning robot who was my child. She stated, I know you think you know. I know you wish you did know, but I have the medical degree and my medical background and specialty is the brain. I promise you, he's not doing anything. I got a second opinion a few days later because I was terrified by the continued malfunctioning robot displays that were increasing in severity and consistency. When I called to inquire and explain I had no other way to describe my child and was desperate for a second opinion, the doctor called not even an hour later and said, I must bring Tyson in the next morning, first thing, even before the office opened, so he could see him. He knew that Tyson's specific brain injury was hugely associated with and susceptible to a dangerous type of seizure disorder known as infantile spasms. Yes, Tyson showed the telltale signs. He was having uncontrolled infantile spasms, clinically via EEG and observationally. Months of intramuscular injections came due to the length of time this had gone on. And in case you were curious, we do continue to see this neurologist who gave us some actual help. He's an amazing practitioner. Now remember, these stories I'm sharing with you are happening in rapid succession. We are not talking about years, but rather in weeks. And lest we forget, Tyson's going to die any second now. By now, I have resuscitated my child twice by bag masking him, and our emergency room knows us on a first name basis. We've made multiple paramedics cry due to our situation. I have our primary care physician's personal phone number, and we use it regularly. She is officially on call for us 24/7. We have Tyson's room in the pediatric intensive care unit at this time. We know the staff and have our preferred people. I can still tell you the specials that rotate through every week at their cafeteria. While enduring all of that, an untold number of medical and service providers asked how I knew he was in there. And I didn't per se, but the thought of him being in there was nice. At times, the feedback from these individuals affected my parenting, how often I held him, what I did with him. It made me question if I was literally losing my mind. Was I living in an alternate universe? Did I think more of my child than what he was? Could he really, truly be in there? Can my love for my firstborn be overshadowing the truth? I had providers telling me I was giving my essentially brain-dead son way too much credit, that he wasn't able or capable of doing anything ever. Expect nothing but death. Love him to death, you crazy mother. There's nothing more than that for you or him. Now, it's easy to forget. Once early intervention is triggered, the family is likely still dealing with coming to terms with the diagnosis or diagnoses. They're having a variety of emotions in relation and are now being told their child needs early intervention. But most families don't really know what this is or what it could or should be. They likely do not know if the services they are getting are best practices, necessary, or relevant to their child. The more diagnoses or disabilities, the less likely a family is to make sense of it all. There are a rotating cast and crew of case managers, service providers, and many others that are suddenly in your home. Can you imagine? They are judging the state of your home because for some, it's literally part of their job. They judge how you look. When have I showered? Unknown. Do I have clean clothes on? The doorbell rings too often and the dog barks furiously every time. You can't nap or rest. And what is this person's name? No clue. What's their specialty? Why are they here yet again? Upon our first meeting with the case manager, Tyson was asleep in an angled bassinet to prevent aspiration of secretions. She breezed in, plunked herself down on my couch. Hi, I'm Bethany, your EI case manager. So, first question. He always like this? Pointing at him. What? Do you ever hold him? How often would you say you hold him? Every couple days or less than that? Yeah, nice to meet you too, I guess. And I remind you, dear audience, he was asleep like so many babies often do. Try and remember you're in their home and you're taking up space in their minds, not just in their homes. This is their child, and this is nerve-wracking. Believe they are trying their best to navigate this new landscape, are capable of making informed decisions with the best interests of their child or family in mind. Be relaxed, non-judgmental, warm, and open to the family and the child. Assume they are competent, capable, and available to interactions, feedback, and suggestions. You might surmise I just gave that advice for a reason, and you'd be right. You know I have a story to tell. During the early intervention physical therapy initial visit, the physical therapist flew through the door, not knowing what she was walking into. It appears she was expecting a mostly functioning child. Tyson was sitting in a comfortable, relaxed, reclined baby chair, oxygen on his face, and he looked like a newborn, though he was months old due to failure to thrive. He is not moving because he literally can't. He's just chilling, as we called it. Please keep in mind, all this woman does is pediatric PT and early intervention, and she has literal decades of experience. She walked over after I introduced myself and Tyson, laid one glance upon him, pivoted her upper body, and said, and I quote, "I don't know what you want me to do with this." And yes, that hand motion is a real thing. Let me say it again so you can really take it in. I don't know what you want me to do with this. This thing that she doesn't know what to do with is my terminally ill baby, my firstborn who I adore and I'm terrified of loving, and I also don't know what the hell I'm supposed to be doing with him. Like most, I expected a healthy, perfect baby, but instead I got this. This professional doesn't know what to do either. He's not even a person to her. What am I thinking, treating him as a person? Is that right or wrong? Questioning my parent choices and feeling alone with a very sick baby, a baby who doesn't see or hear me and doesn't know where he is or who I am. Or does he? A provider who specializes in deaf blindness, Ms. Emma Nelson, who is doing an NCHAM webinar next week and is a true treasure, came for her planned second visit. I must have mentioned something about my questioning of Tyson's abilities and availability. Her advice? Assume competence. You don't realize it, but you already are. Keep going with it. Take it further. Always assume competence, that he understands and is paying attention even if he can't show it. I was floored. I probably looked like that emoji with the top of its head blowing off. No one had ever suggested this. In fact, always the complete opposite. It's what had made me question my own abilities as a parent and sometimes my sanity. She believed in Tyson and in me. She assumed we were both competent, simply that we needed a boost of skills, empathy, and safety to learn and grow. But how would I know that Tyson was actually competent? One day, while sitting in a recliner with our small-sized dog cuddled next to my hip, the barky one from before, and baby Tyson resting in my arms, I was watching TV. I felt someone looking at me. Many of you probably know the feeling I'm talking about. I kept watching the TV, but continually felt that sense of being watched, yet I'm home alone. Or am I? I gazed down to my left, and there was Tyson. Are you looking at me? Do you see me? Not through me, not nothingness, but see me. It was eye contact. He'd found his mama, and I saw him too. He was in there. I wasn't crazy, I wasn't wrong, and I wasn't a bad mother for wanting him to be in there, because he was. We built upon that immediately, always rewarding attempts at eye contact. It was our first communication. We connected. I was fearful, I can't deny that. In the beginning, I questioned if I was making it up. Assume competence, I kept reminding myself. Tyson used to smile only when he was having a seizure. It was both beautiful and absolutely heartbreaking. But don't worry, I didn't bring those videos today. To think this would be the only way I would see my boy smile about killed me on multiple occasions. Tyson's fourth birthday rolled around, which we weren't supposed to see, as you recall, and I assumed, like every other birthday, it would be filled with wonder and extreme pain and difficult emotions. The trauma often suffocated what could be a special day. On this birthday in the late afternoon, I did something, I don't recall what. Tyson smiled, but he didn't seize. He just smiled. And I swore loudly, holy shit. Questioning my sanity once again, I tried to replicate the smile. For a while, nothing, but a few hours later, I came into his view again, and he smiled. It was real. He was capable of emotions, glad to see me. The dog came over not long after and licked his hand, and Tyson smiled a half Elvis grin. I cried for hours. Happy birthday to us both. It was such a gift. Last example, and it's probably one of my favorites. For a child that was only to live 8 days, his birthday and those following 7 days have always been a very difficult time, consistently filled with deep emotions and anxiety. I wanted to make it to 1 year, then 2, then 3. Then I wanted 5, half a decade. As time progressed, I could see a big goal in sight. 8 years. Could it be possible? Yes. Yes, it could. It did. This child who was supposed to live 8 days lived his entire 8th year and just turned 10. Talk about joy, happiness, tears. This kid that you see on the screen, he's truly something magical. It's incomprehensible in so many ways. And now we're dreaming big for 13 to make it to teenage. So what does all of this mean? It's okay to assume best intentions. Feel positive about that choice. It's never wrong to assume the competence of the person before you. Treat them like a person. Allow the child to lead the way when possible. You aren't hurting anyone by teaching them autonomy and self-worth. And though it's cliche, there are true life lessons to be learned when we treat others the way we wish to be treated. Assuming confidence feels good to all parties involved in the interaction, whether they are currently able to express it or not. By assuming competence, I believe Tyson found reasons to stay. I know it won't be forever. I'm acutely aware I'm on borrowed time. But these moments of realizing he's in there have been life-changing. Treat him as though his body is betraying him, but his personality, his true being is alive and well and capable in his own ways. It's simply going to take time and a whole lot of effort between himself and a communication partner to coordinate letting it out. I wasn't wrong in following his lead, no matter how slow the journey is sometimes. These moments changed everything. You can have this for your child or family, or assist in creating these core memories for the families you work with as well. So lessons and takeaways. When best practices according to the professionals conflict, you need to have a strong ability in your competence. Silos, stay in your lane, but have awareness of the cars around you. Is there an exit coming up? Prepare the family. Nonverbal does not mean non-communicative. Positivity and belief in the child and family is critical. And if you assume competence, the family will follow suit. It's okay if they need to have encouragement or gain self-esteem in this area. Assume competence in both the child and the family members. And don't forget to assume competence in yourself. Lead by example. It's easy to focus on your own specialty. Of course, this is important. However, sometimes it's as important to learn about who else is involved with the family. What proverbial cars are around you? You may be giving suggestions or homework to the family, but is there a traffic jam? How many others are also giving suggestions of things to work on daily to fit in along with household duties, medical appointments, work? And don't forget to connect with your child. Families often hear two conflicting messages. Do all of the things in the best interest of the child, but don't do all the things to avoid burnout. Connecting with your child is number one, but it's also super important that you do XYZ daily or terrible things may happen like no progress. For some of us, being told what to do means we will at the expense of many other things. The awareness and teamwork needed amongst all providers is critical to helping find a balance that treats the child and family holistically. We are just trying to keep our highway clean. You can assist by ensuring there is regular communication amongst everyone who works with the child or family. This also takes the stress off the parent, who no longer has to play an intermediary or a go-between. When important changes are coming, the more notice, the better. That includes changes in providers, case managers, or moving into the school system. When possible, these things should not be a surprise. Families need time to prepare for that exit that is approaching. By giving extra support if needed, families can go into these changes feeling prepared, confident in the team, and competent in their abilities to adjust to said changes. This increases feelings of independence and self-worth. And if I may, please let me stress, nonverbal does not ever mean non-communicative. Too often professionals are putting the two as the same and teaching families this lesson. They are not the same. Communication bids, while not necessarily using the language of the majority culture, does not mean they do not have the ability to communicate. It might be via oral language or sounds, sign language, body language, behavior, eye gaze, manipulative systems, touch cues, and many other ways. Tyson communicates via vocalizations, meaningful blinks, eye gazes, tongue movements, and or attempts at making noise, though only air comes out. Depending on his alertness, health status, and other variables, Tyson will use one or more modes of communication to get his point across. Because each and every one of these were responded to as a bid for communication, he made the connection that I understood. Noises changed over time to clear, repeated sounds for yes or no, like, dislike, annoyance, or happiness. And they are not the same two sounds used as positive and negative. He has a small repertoire. If a communication partner is not noticing these as anything other than a special needs kid making noise, they are losing an incredible opportunity to get to know Tyson. Finally, you must lead by example. If you assume you are competent, the child is competent, and family members are also competent, with dedication, best practices, and yes, hard work, the sky is the limit. And no, children like Tyson are not going to get up and sing and dance no matter how hard anyone works, but they may learn to enjoy watching, touching, movement, music, or any other number of things that vastly expand their quality of life. These are huge milestones for children who have multiple disabilities. Never underestimate the power of reaching a goal. Ensure you know basic skills such as wait time, and there is so much waiting, but the wait is worth it. And respond to any change as if it's a bid for communication. The child, when assumed competent, can make connections after much repetitive work. Don't miss these tiny bids of connection because you're looking for the big ones. If you believe in your own capabilities of seeing it in others, your work grows and expands. You become competent and a well-rounded provider. So what can I do? Action steps. Assume your competence by adjusting your mindset on the child and family. Believe they're available, able, and capable no matter the communication mode. That the child is capable of communicating. The burden is on you to recognize it. Believe in the best in yourself. Are you seeking best practices for your profession or family life? Check in. Are you having positive interactions and truly enjoying time with the child or family? Believe the child's diagnoses and or disabilities do not prevent them from connection, learning, absorbing, changing, growing, loving, or having wants, needs, and preferences. Understand any child is a whole being with thoughts and feelings, whether they are currently able to express them or not. And if this is an area you feel that needs work, trust you can start the changes now. You can start big, start small, just start. Believe you are capable of change. It might not be easy, but it is feasible. Don't discount reaching out to mentors, leadership, coworkers, agencies, organizations that are related. You can also suggest or seek associates who will help you in creating a working group or support group. You can learn from each other. You can also invite guest speakers and family members. So what are the systems that require changing to make assuming competence a natural part of EDI, educational systems, and families? It starts with individual thought processes, then moves to agency or organizational leadership, then policies and procedures through the Department or Agency of Education and legislation. And then you have educational institutions and medical systems. I know that list seems short, but it is also very overwhelming, and I'm sure some of you are nodding along with that. So what are the benefits of assuming competence? Increased self-esteem for the child, family members, and professionals. Increased self-worth and self-confidence for the child. Increased communication and connection for and with the child. More appropriate policies, procedures, rules, and regulations. Legislation that supports individuals with disabilities and medical complexities. Excuse me. Increased funding for programs and other supports that benefit individuals with disabilities and medical complexities. Changes in medical providers, their staff, service providers, and educational teams' approaches, terminology, suggestions, and decision-making processes. And changes or shifts in societal views, more positive views, and acknowledgement every person is not only capable of being, but actually is a productive member of society. So did you notice the theme? Increased, positive results. Assuming competence as a natural policy and position has untold benefits for all, from micro to macro changes. Top down, bottom up simultaneously is likely the most productive way to create change efficiently. We should not wait for a trickle-down effect. Instead, utilize the theory that a larger collective can create more significant change. Ensuring policies, procedures, best practices, and personal values include assuming competence will automatically create seismic changes across all parts of society. Something seemingly small, such as one child or family, can begin the ripple effect. Enough ripples become waves, something that is not so easy to ignore. The same goes for the learning process for a child. One notice of their bid for communication or show of understanding increases the possibility of it occurring again. It's positive reinforcement. But I don't know what to do. Take a breath. It's okay not to know. Give yourself permission to acknowledge that you're not positive or know the answer at all. Do not shame yourself or the person asking. Beware toxic positivity and otherisms. Then do your due diligence. You can ask coworkers, search the internet, check even seemingly oddball options such as Reddit or Facebook. Most importantly, don't push away. Pull the individual or family towards you. Trusting relationships create safety for learning, trying new things, and feelings of being accepted and understood. So many times when I discuss assuming confidence, I hear a lot of feedback. How will I know if I'm doing it right? I don't always have the answers. And even after all you're talking, I still don't know what to do. And that's okay. You're not expected to always know. You'll never always have the answers. You may be asked something that you simply have little to no knowledge of. You may not know what to do with this, but you find out and respond accordingly. Take a deep cleansing breath and give yourself permission to be honest in a kind way. If you give clear information on next steps you will take, when you will get back to them, and follow through, families are going to take you seriously and not question your abilities. That competence you are assuming in them will be reciprocated back to you. If you panic, fib, avoid, or discredit the request or question, you automatically lose any level of professionalism the individual had in you. There's no shame in not knowing. We are all learning every day, but there can be intense shame for responding inappropriately, and that will influence who you are and how you act personally and professionally. If you say something out of turn, take a few breaths and collect and correct yourself. If you're embarrassed or feel a failure, it's okay to seek help from a counselor, mentor, or coworker you trust. No one is perfect. I do caution you to beware of falling into the trap of what is called toxic positivity. Everything is not great all the time. Everything in life will not be okay, and unfortunately, that has to be okay. Constantly turning a moment of vulnerability into everything will work itself out or everything happens for a reason, you'll see, or any other number of statements will sever a relationship you have built. I promise you the family will not feel safe or trusting. They will feel unheard, unseen, and it may lead to feelings of rejection or isolation. In a moment of vulnerability, you can validate how difficult what is being shared sounds. You might not be able to fix it, and throwing around toxic positivity isn't going to help at all. Be real, and if you think you can help, make the suggestion. If not, uncomfortable though it may be, you may have to sit with their pain. This work isn't easy and definitely isn't for the faint of heart. You can do this, though. It's a skill you can learn, if not innately inside you. And lastly, I want to acknowledge one of the newer major negatives, otherisms. This can come out most frequently in language used to describe families, but also in views or opinions on families. It influences one-to-one work all the way up to policies and procedures. Do you discuss families as a collective using they regularly? As in, why don't they just do X, Y, Z? I don't understand why they don't do what we say. Why do they need more than one communication? They are annoying and time-consuming. These are the nicer examples that have been stated to me in recent weeks. And all I can say is, that doesn't sound so great to me. It would not feel great if I said, why don't they, all the providers, get a clue there's more to family life than you? That sounds trite and terribly offensive of me. Avoiding otherisms is being cautious of an us versus them mentality. And I know it's hard. And sometimes you're not going to agree with the decisions or actions a family takes. And sometimes families won't agree with yours either. But by avoiding otherisms and viewing these situations from a team standpoint, you will feel a sense of camaraderie and good intentions. You are assuming confidence. You are all on the same team because you've earned your spot. Lastly, try to look for the best in a situation, even if you're uncomfortable or unsure. Ask yourself, what should I do? What feels innately right? Believe you're capable of making an informed choice. Trust me, children and family members know when you're faking it and when you're pushing us away. We know when you actually see us, believe in our abilities, and genuinely support us. And we certainly know the difference between what feels phony and what feels real. So ask yourself, how can assuming competence help you personally or professionally? Can you think of ways to incorporate assuming competence into your life? How can talking about your emotions around shame, mistakes made, and not assuming competence assist you? Have you ever had an experience where someone in a position of power thought you weren't capable or knowledgeable, felt as though you weren't seen or believed? How did you feel in that moment? An additional question to reflect upon. Are you willing to allow others to take the lead and trust they know what is best for themselves or their family? Recognize that when you're assuming competence, you are partaking in both leading and following. Can you learn from your missteps and do better? Give yourself permission to say, I'm not sure, and be willing to be vulnerable enough to be Tyson tough. Now you may be asking me, what is she talking about when she says Tyson tough? When Tyson was born, we attempted to come up with a family slogan to rally our own emotions and rein in catastrophic thinking. Tyson tough is what we landed on. A nurse thought we were bonkers for having a family slogan, but trust me, it helped to steady the ship more than once. When I felt I was spiraling, I'd take deep breaths and repeat it. Do you need to feel good? Do you need to feel good? Excuse me, sorry, my phone just went off too. Do you need a feel good slogan that happens to include the idea of assuming competence, one that centers you in tougher times? Assume your competence to find one that fits and use it as much as you need. Don't let it be embarrassing or shameful. If it works, it's great. I don't think you're bonkers for using any method that is safe that helps you. So I really want to thank you all so much for sticking with me today. I recognize this was an emotionally and mentally involved session. I'm incredibly grateful for your time and attention, and choosing to be vulnerable with you all has been another lesson in me assuming competence and an audience being able to sit with this and with me and with Tyson. And here you all are. After the question and answer session, off you'll go to assume confidence with others and be Tyson tough. Thank you.
Thank you, Michelle, for a wonderful presentation. We've a lot to learn. Want to give you a chance to take a drink of water and for some questions to come in. We've got some comments right now saying, wonderful, thank you. This is so valuable and important, and all medical care providers should be required to watch.
Agreed.
Yes. And thank you so much for this presentation. I relate so much to Tyson's story and love the opportunity to get to know Tyson. I'm loving already Tyson's mom.
Thank you.
So we were also asked if this presentation is in Spanish, and we do not have it available in Spanish, but so sorry about that. The presentation will be, has been recorded. It will be online in the next few days at infanthearing.org, and please share it with providers, families, friends, everyone. Happy to have that. So I have a question that I'll ask while others may come in. How do you share with parents who are starting out on this journey to assume competence in themselves? A lot of this is talking about providers and how they should assume competence in the families. But if you're in the thick of it as mama or other, dad, how do you start?
Yeah, I think that's a great question. I think unfortunately it starts inward, trying to believe that you have the ability and capability of being an appropriate parent, of having that innate sense of knowing what's right and wrong. And hopefully some of these families have counselors, right? There's that part of me talking, but I think being able to build up self-confidence and self-esteem is so critical. And I do think while it's very important to have that come from inside, I will say, because so many families see so many medical and educational and service providers, that having those outside mirrors reflecting back what you're trying to feel inside is really empowering. I do feel like it's a team effort, which most people don't love that answer, but it is.
Thanks, Michelle. We've got lots of thank yous for this presentation. Thank you for sharing your journey and Tyson's life with us. Powerful. We need the families to hear your story as well, not just providers. I think, I'm assuming that's what that implies. Thank you so much for sharing your story and assuming we all want to increase our competence in supporting families. I hope that all parents will see themselves as an expert on their child. Providers might be an expert in subject area, and parent subject areas are their child, so they are experts in that subject field. So reminding parents that they are the expert on their own child.
100% correct. Absolutely.
So thank you so much for your vulnerable presentation about the realness of raising your son. So important. On those days when Tyson Tough is waning, what coping strategies do you rely on to get back on track?
Yeah, that's a great question. And I have had many days, months, and even years where that hasn't always been, the most skilled set of mine. A lot of it is trying to remind myself that I just need to get through this minute, this hour, this session, and start small. It's much like people say when they have a hoarded room, just start with one box. I think sometimes people can get overwhelmed looking at the whole picture. How will I get through this week, this whole day? And sometimes you just have to say, like, can I take a minute? Can I splash water on my face? Can I regroup? And if I can't, I have had to learn, because I was not good at this at the beginning, to reach out to friends, and maybe you have family, a counselor, a provider, whatever your support system may be, neighbors, other families. It is so difficult to be vulnerable, but it's really important, because that isolation can lead to a significant amount of depression and anxiety. So I say from my own experience, on those harder days, I have to find the willpower to keep going. And excuse my language, but sometimes it really sucks. It really does. I'm never going to deny that, but it is so critical that we put ourselves and our children and our families first in order to keep going.
Thanks, Michelle. We've got a few more questions coming in. So I think this is a great one. How do you know when you're using toxic positivity versus just positivity?
Yeah, that is a wonderful question. I know when I added this in, I thought, ooh, this might be tough for people to hear. I think it's important to be positive. It really is. So I don't ever want to take that away. But toxic positivity is no matter what, it's going to be fine. So when a family's saying, I have no idea how I'm going to pay the electric bill, and like, don't worry, it's going to be fine. It all works itself out. It's just not going to. That they need help. But being positive can look really different. Like, well, we can work together and try and figure out how to pay your electric bill, or let's see if there are grants available or programs. And certainly around, children and their well-being and education. I think there is being positive, that we're gonna try and see if we can get, little Joey to fill in the blank. But it's not, well, no matter what, everything happens for a reason. Nobody wants to hear that. Like, nobody wants to hear that their child has autism for a reason, or God only gives you what you can handle. Nobody likes that statement either. So I think it's those cliches that are toxic. I think being positive is more being supportive, if that's helpful. And if it's not, throw that in the chat and say, no, try again.
Thanks, Michelle. Are there support groups that you have found meaningful to you?
Yeah. So again, took me a long time to be willing to kind of delve into that. But yes, disability specific has been really helpful. Hope for HIE is one for children with the brain injury like Tyson. I at first just joined their Facebook group and just watched and tried to feel comfortable and take it in. But yeah, I will say I really was both isolated because of where I live, but also isolated myself for a long time. So depending on where you live, there are in-person support groups. Certainly online, Zoom has become a life changer for many families. And your state probably has a parent information center, and you could also reach out to them for resources.
So we have a question about love languages. Do you know what Tyson's love language is? What's his favorite way of being shown he's loved? This person is reading love languages for children in school book club.
Yes. Yeah. It used to be gifts, because he likes looking at things, and now it's time. He just loves people and spending time and having undivided attention and people making of him. It's his favorite. He wants the attention no matter where he is. And if he doesn't get it every once in a while, he'll yell. And then I have to say, yes, everyone knows Tyson has arrived, moving on. But yeah, time is a big one for him.
Okay, we've got time for one more question before we wrap up. Are there some suggested training opportunities related to toxic positivity?
Ooh, that's a good one. I don't know, but I'd be so thrilled to help with that.
Yeah.
So you could email me and I can work on that. I don't know, honestly, offhand, but it is becoming a huge thing in psychology, and certainly I think picking up steam in education and service providers and even in the medical field. So I'm sure that there are. I just don't know of any off the top of my head.
Well, you're being encouraged through chat to do it. So add that to your list of things to do. Again, thanks for your presentation or coming through the chat, wishing it was available in other languages. So thank you again for your time. Don't forget to fill out the evaluation and certificate at the end of this session. Gunner's going to bring that up. Thank you so much, Michelle. You're so appreciated, and this presentation has been wonderful. Thanks to everyone who participated, especially our Michelle and our captioner and interpreters and all the people behind the scenes making all of this work. If you have any questions, Michelle's email is on the screen, and be sure to fill out the certificate of attendance / evaluation form. Thanks, everybody. Have a great day.